today we are going to have very important topics in dermatology. It is not purely dermatology, it is dermatopathology, which is an integral part of dermatology. And every student should know dermatopathology, and we are giving too much of importance, or rather importance, to dermatopathology in day-to-day practice. So we thought it is good to have discussion on various aspects of dermatopathology. And today we are going to have two eminent speakers to tell something about dermatology. One is Dr. Meera Rajan Panniculitis. And all of you know that Professor Meera is a very well-known dermatopathologist. She is presently Professor of Dermatology in CMC Vellore. And she has a lot of interest, and she has proved her mettle in dermatopathology. So she is talking about panniculitis, which is very confusing. And I'm sure Dr. Meera's topic and presentation will give a good idea about panniculitis, and when you come across panniculitis, how to go about. So we welcome Dr. Meera Rajan Panniculitis, for her presentation. Over to you, Dr. Meera.
Thank you, Dr. Crichton. It's always a privilege for me to be associated with Amala and everything that you do. Dermatopathology is something which I cherish, and I hope the little things that I can tell you will benefit all those who are listening. I love teaching, and I hope this will help those who are listening. Let me see. Can you all see my screen?
Yes, madam, it is opening now.
Not.
Is it? Okay, thank you.
It is open.
Okay, I'm also known as Meera Thomas, though my maiden name is Meera Rajan Peter, and officially I'm still Meera Rajan Peter. I'll just, yeah. Is it clear now?
Yeah.
Yes.
Okay. So panniculitis is, like you all know, is a heterogeneous group of disorders which involve the subcutaneous fat. They are diagnostically challenging, not only for the dermatopathologist, but for the dermatologist as well, because it looks very similar on examination. All the lesions look almost alike. And the subcutaneous fat responds to different insults in a very limited number of ways. For example, if you look at this clinical picture, they all look indurated, maybe some nodule here, maybe some another induration with a plaque, an ulcer, but they all look so similar. But there are numerous conditions which are different and can be treated differently. So let me get to the basics first. This, you know, is the normal skin. A 4 millimeter punch will show you the epidermis, dermis with the skin adnexal structures, and the subcutis. Now, subcutis is what we are interested in today, because that's what causes panniculitis. If you do a biopsy like this, do you think it's good, bad? What do you think? Anybody want to hazard a guess? Okay, I think it's a bad biopsy, because especially when you're saying it's an induration of the skin, there's hardly any panniculus. So we may be giving a wrong diagnosis, saying there's nothing wrong, when actually the condition is deep down. So always remember, in a case of panniculitis, take a deep biopsy so that the subcutis is involved. The subcutis is thinner in the eyelid and scrotum, thicker in the hips and the buttock. So you should get a biopsy like this for a good diagnosis of panniculitis. So panniculus involves adipose tissue, which is divided. This is a nice mature adipocyte, which has the nucleus towards the periphery, nice pentagon shaped with a clear cytoplasm. They're divided into multiple lobules by thin fibrovascular septa. And like you see here, you have the smaller arterioles and venules in the center and the larger arteries and veins in the septa. So what happens is any lesion which involves the arteries and veins usually is seen in the septa. The artery is closer to the center, so you may have one lobule which is involved, whereas the arterioles and venules involve the capillaries, involve the lobules because they are seen right in the center. Now here's a lesion which is seen in the septa. So you have just a little bit of inflammation here. So this is a mild septal involvement. So panniculitis per se, the first thing that you'd ask yourself is, does it involve the septa or does it involve the lobules of the panniculus? So that's question number one. Is it septal or lobular? Now, if you have a lobular panniculitis, it's usually because the arterial supply is involved. Whereas if it's a venule which is involved, you usually get a septal panniculitis. Now, there are two good articles which anybody who wants to read can look through it because it gives a beautiful description of how to go about diagnosing panniculitis, both by Uma Nahar and Velasco. Now, the 5 cardinal signs or things that you should look for when you have panniculitis. The first thing I told you, ask yourself, is it septal or lobular? Look under LOPA. The next thing you ask yourself, is there vasculitis or not? If there is vasculitis, is it a small vessel or a medium-sized blood vessel which is involved? The third thing you ask yourself, is there any inflammation? If the inflammation is present, what sort of infiltrate is it? Is it a neutrophil? Is it a lymphocyte? Is it a histiocyte? Is it a eosinophil? Are there granulomas or not? That's the fourth step. You ask yourself, are there granulomas? Is there any other change, any type of necrosis that is present? Is there any calcification? Are there foreign bodies sitting there? That's the next thing that you will look for. So I have put it as 6 steps, so it's easy for you to remember. And if you just keep on using these 6 steps, you can diagnose any case of panniculitis. So here's a skin biopsy. I've just cut into 2 bits because I didn't have a 2x scanner. So this is the epidermis, which is unremarkable here. And the subcutis, the dermis too is unremarkable. The subcutis shows involvement of one part. Can anybody message in the chat which part is involved? Is it the septa or the lobule which is involved? Anybody? What do you think? You've got somebody writing something. Somebody has written something. I can see that. Septal. Good. So it's predominantly here, it's a septal panniculitis. Now look at this. Here, you have predominantly the lobule that is involved, except that there's a little bit of inflammation also at the septolobular junction. Very rarely do you get a pure lobular or a pure septal panniculitis. Usually it's a mix of both septal and lobular that we usually see. So you've decided it is septal or lobular. 2 things to remember. Adults usually have equal numbers of septal and lobular panniculitis with or without vasculitis. There's a whole host of differentials with that. Whereas children usually have lobular panniculitis. The number of entities in septal panniculitis are very few in children, whereas in adults, you have many entities in both septal and lobular panniculitis. So now you've decided if it's septal or lobular. The next thing you ask yourself, is there vasculitis or not? If a large vessel is compromised, there's very little inflammation and just the lobule adjacent to it is involved. Whereas if a small vessel is involved, you have extensive inflammation and a lot of necrosis. That's something which you must always keep in mind. So here's a vessel. Here's a vessel which is showing transmural inflammation, some endothelial cell swelling, and focal endothelial cell dropout. So that makes it small vessel vasculitis. So you should have transmural inflammation with either endothelial cell necrosis, endothelial cell dropout, keratic debris, or fibrinoid necrosis to call it vasculitis. The same thing here. You have transmural infiltrate of lymphocytes here and some histiocytes with loss of endothelial cells, which makes it small vessel vasculitis. If you look at this is a septal panniculitis with little amount of lobular. And if you look at this large vessel, there is no inflammation. So there is no vascular involvement here, though there is septal and lobular panniculitis. Look at this. Here you have a larger vessel which is showing transmural inflammation. Unlike a small vessel, in a medium-sized blood vessel or a large vessel, all you need is transmural inflammation to call it vasculitis. In a small vessel, you need to have either endothelial cell necrosis or fibrinoid necrosis or cataractic debris with or without endothelial cell dropout to call it vasculitis. So here's a medium vessel. You need to know if it's an artery or vein because you have to say if it's superficial thrombophlebitis or medium vessel vasculitis. The entity changes from pan to superficial thrombophlebitis. So this is a medium-sized blood vessel. That particular lobule is involved. You can always do an Aucene or an EVG stain, which will show you the internal elastic lamina. If internal elastic lamina is present, then you know it's an artery. If it's absent, it's a vein. So that's easy, right? So you've decided there is septal or lobular panniculitis with or without vasculitis. And if vasculitis is present, is it small vessel or medium vessel which is involved? The next thing you look for is with necrosis. Necrosis is defined as pycnosis, karyorrhexis, and karyolysis. That is, shrunken nuclei, fragmentation of the nuclei, and breakage of the cell itself. In the case of the panniculus, you have either anucleated cells or complete dissolution of the structure or just absence of nuclei. All these can be seen when there's necrosis of adipocytes. Now, necrosis of adipocytes can be of 7 types. One of them is lipophagic fat necrosis, which you will see either in traumatic necrosis, erythema induratum, or erythema nodosum, where what you find is you have a lot of foamy histiocytes, like you see here, in the center of the lobule. Usually when you see foamy histiocytes alone, always remember you must ask for special stains. You ask for PAs, you ask for grams, you ask for TB, you ask for LEP. In case they're all negative, then you say there is lipophagic fat necrosis. The next thing, and you have to have a good clinical history where there was trauma at that site, or did you have other features of erythema nodosum. The next type of necrosis is liquefactive fat necrosis, where you have granular wisps of amphophilic material with some cataractic debris, usually seen in young children with alpha-1 antitrypsin deficiency or in pancreatic panniculitis. Acute pancreatitis, you can get this amphophilic wisps of granular material seen in liquefactive fat necrosis. The third type of fat necrosis is enzymatic fat necrosis, usually seen in pancreatic panniculitis again, where there's saponification of the fat cells and you have the ghost outlines of the fat cells, like you see here. That's what you would see in enzymatic fat necrosis because of the enzymes present in pancreas, which break down the adipocytes. The fourth type is hyalinizing fat necrosis, seen in lupus or lipodermatosclerosis, where you have mummified anucleated adipocytes surrounded by a hyalinized glassy eosinophilic material. You can also have foci of calcification, like you see here. It's a higher part of the same. So that is hyalinizing fat necrosis. Then you have an entity called membranous fat necrosis, seen in lupus or venous stasis, where there's cystic dilatation of the fats, the adipocytes, and each adipocyte is thrown into a feather, has a feathery appearance, like this. It's called an arabesque pattern or a crenulated appearance of the fat cells, which is called membranous fat necrosis, usually seen in lipomembranous change, can be seen in lupus, venous stasis. There are a whole host of conditions which can have lipomembranous change. The sixth type is ischemic fat necrosis because of impaired blood supply, usually seen in the center of the lobules. Now here the adipocytes present, as they're smaller in size, the outlines are preserved, but the rest of it is all degenerated. You cannot see any nuclei in that site. You can see it in calciphylaxis. You can see it in erythema induratum. It's one of the few areas where you can see it in DIC as well. Here again, you have the fat spaces, which you can only see the outlines, no saponification, but they're smaller in size. The cell size is preserved. That's ischemic fat necrosis because of loss of blood supply to a tissue. The seventh type is basophilic fat necrosis. Here, because of necrosis of the adipocytes and inflammatory cells which have got into the panniculus, the neutrophils break down and produce keratic debris, which are blue in color, giving it a basophilic hue. So it's called basophilic fat necrosis. So now you've seen whether it's septal or lobular panniculitis. You've seen the type of vasculitis which is present, whether it's a small or large vessel, medium vessel, whether it's a vein or an artery which is involved. And you've seen the 7 different types of necrosis, starting from lipophagic fat necrosis to basophilic fat necrosis, and the different conditions associated with each type of necrosis. The next thing you look for is what inflammatory cells are there. If you see neutrophils in the panniculus, you think of septic panniculitis, like I showed you here, or an early erythema induratum. If you see eosinophils, think of drugs, think of fungal or parasitic infections. If you see foamy histiocytes, you always should think of fungus, bacteria, both acid fast as well as LEM. If you have lymphocytes, think of lupus or a lymphoma. So in the first 3, you should always ask for special stains if you see any of those cells in the panniculus to rule out infective etiology, and then only come to a diagnosis of what other causes could be associated with these inflammatory cells. So here you have numerous neutrophils sitting here with small foci with some basophilic debris. It's like a basophilic fat necrosis here. So what would I do? I would ask for gram stain. I would ask for PAS. Here, if you see gram stain done, showed numerous gram-positive cocci or staph within the panniculus, giving you a septic panniculitis with gram-positive cocci. Here's another one. The epidermis is normal, so is the dermis. But if you look in the septa of the panicule, you've got some infiltrate. Go on the higher part, you've got a lot of foamy histiocytes, some neutrophils, some eosinophils thrown in. So when you have this, what would you do? You would ask for special stains, right? So this is PAS positive. You have pseudohyphal forms and yeast forms of Candida, showing you invasive candidiasis. So that's about the inflammatory cells. The next thing you look for is granulomas. Usually granulomas are seen in the septum, but they can also be seen in the lobules. There are a whole host of infective and non-infective etiology which can have granulomas and can be seen as panniculitis. I've just listed a few of them which are commonly seen, but if you look at the textbooks, you'll find a whole host of them. Remember, granulomas usually in the septum are not associated with vasculitis, like in erythema nodosum, but granulomas in the lobules are usually associated with vasculitis, though it's not 100% rule. It's just that most of the time, if you have a lobular granulomatous panniculitis, usually you should look for vasculitis. Here is a panniculitis with granulomas. Something else which you notice is there is a large nerve as well. So here you've got granulomas. Can you see them? Surrounding the nerve with few inflammatory cells going in. So that tells you that there is a granulomatous panniculitis with perineural involvement, with extension into the dermis and a Gren zone put in here. So that's usually what you would see in BT Hansen's disease. Next is looking for the other changes that you can see. So you've got a septal or lobular panniculitis with or without vasculitis. If vasculitis is present, you need to decide if it's small or medium vessel. And if it's a medium vessel, you need to do special stains to identify if it is a vein or an artery. The next thing you'll do is 7 different types of necrosis. Check out what type of necrosis it is. Then you look at the inflammatory cells, NLHE. Easy to remember. If it's inflammatory cell in the first few, then you always must do special stains to exclude the infective etiology. Otherwise, think of non-infective causes of panniculitis with like lupus or a SPT or a lymphoma. Then you look for granulomas, which can have either granuloma annulare or a sarcoid or a gout or erythema nodosum or ENL. Not ENL. Erythema induratum of Bazin, which can be seen in TB. All of them can have granulomas. The next change you should look for is other intercellular changes. Like, for example, you have calcification in small caliber blood vessels, which you would see in calciphylaxis, which is a medical emergency, which is a critical report, which you need to tell your clinician so that they can immediately check out if the calcium phosphate levels are normal and if a culture has been done, because that can lead on to septicemia. You must also look for thrombi within blood vessels, where you can see it in DIC or in a cryoglobulinemia, where you may have a lot of plasma cells as well. Or you look for needle-shaped crystals, which you can see both in subcutaneous fat necrosis of newborn and post-steroid panniculitis. But remember, in scleroderma neonatum, where again you can see these needle-shaped crystals, there are hardly any other inflammatory cells. And post-steroid panniculitis can look exactly the same, but you need to have a good clinician telling you the history of an injection or steroid use at that site to know if it's post-steroid panniculitis. You can also have atrophy of adipocytes, making it smaller in size with hemorrhage in lipoatrophy. So now that you've got all these notes in your head, so I'll just put in a few cases so that it's easy for you to tell me if you've understood what I've been talking about till now. First is a 49-year-old female with erythematous swellings on both legs, 3 on the left and 2 on the right, with hyperpigmentation. What sort of panniculitis do you see? Can you put into your chat box? What panniculitis do you see? Okay, I'm seeing one answer. Septal. Okay. So we've got 2 people telling me it's septal. 3 septal. So here is the panniculus. This is the panniculus. You can see the septa here. So is it septal or lobular? Can you see the panniculus septa here? The septa looks clean, right? So the inflammation looks predominantly in the lobules because the septa looks clean here. So this is a lobular panniculitis, where the dermis is almost normal, so is the epidermis. Let me show you the next picture, a higher part of the same. Here you also have involvement of the septa. You're right, there is septal and lobular panniculitis. The next thing, is there vasculitis? Can you see a vessel on top? Is there vasculitis or not? What do you think? Vasculitis present or absent? Okay. Saying somebody, Rajagopal, said that there is vasculitis. When you have vasculitis, you need to have transmural inflammation. If there is no transmural inflammation, there is no vasculitis. Okay. So just having perivascular infiltrate is not enough to call it vasculitis. You have to have transmural inflammation with, if it's a small vessel, either endothelial cell necrosis or fibrinoid necrosis or carotid debris. Here, I am not seeing vasculitis, maybe a vasculopathic change because it's some perivascular infiltrates. I can see some giant cells here. Can you see that? What about the necrosis? What sort of necrosis do you see? Let me take it under higher power. What is the infiltrate like? What cells are these? The dark blue. What are the dark blue cells? Any idea? Dark blue cells are neutrophils. What is the shape of neutrophils? How many nuclei does a neutrophil have? Lymphocytes. Yeah, because neutrophil usually has more than 3 nuclei. So you have lymphocytes, which have dark blue nuclei and scant cytoplasm. Lymphocytes will have more than 3 nuclei. Histiocytes will have pale nuclei. That's how you recognize a histiocyte from a lymphocyte. So here you've got lots of lymphocytes, few histiocytes. I'll show you another section of the same. Here you can see granulomas, aggregates of epithelioid histiocytes with Langhans type giant cells. So few scattered lymphocytes, nice epithelioid granulomas. Can you see this necrosis? What necrosis is this? Can you type it in your chat box? What necrosis? You've got lipophagic fat necrosis, hyaline fat necrosis, lipomembranous fat necrosis, basophilic fat necrosis, liquefacted fat necrosis. Which of them do you think it is? What fat necrosis is this? This that you see. Any idea? Can you put into your chat box? What fat necrosis is this? Okay, I've got 2 people answering, telling me it's lipophagic fat necrosis. Good. This is lipophagic fat necrosis. You also have some hyalinizing fat necrosis here. So take it under higher power. So if you go to the first table which I showed you, but what to look for, what sort of panniculitis do you see here? This is septal and lobular. No vasculitis. Necrosis is lipophagic and some hyalinizing. Inflammatory cells are predominantly lymphocytes, histiocytes with granulomas. There's no calcification. There is no foreign body seen here. There's no needle-shaped crystals, right? So this is what I would call predominantly lobular granulomatous panniculitis with lipophagic and hyalinizing fat necrosis. I won't call it straight erythema induratum because I'm not seeing vasculitis. So maybe a resolving erythema induratum. If there was vasculitis, I would have called it straight away erythema induratum. Clear? So I'll give you one more case. Is there time for one more case? Mr. Naveen?
Okay.
Yes,
Good.
I'll give one more case and then I'll give you the questions. 18-year-old female with indurated tender erythematous plaque on the right thigh of 1.5 years duration associated with high-grade fever. So here you have the plaque, which is tender. What sort of panniculitis do you see? Lobular, septal. What do you see? Put it in your chat box. I think it's septal. Is that what you think? Or lobular? I've got one answer here, which says lobular. Right, this is a lobular panniculitis. Do you think there's vasculitis? Here's the vessel. Hardly any inflammation. So there's no vasculitis. Next thing I'd look for is there's no vasculitis here. Epidermis is clean. Some infiltrate around the sweat gland complexes. What sort of infiltrate are you seeing here? What sort of necrosis are you seeing? What is this? What necrosis is this? Lipophagic, hyalinizing, liquefactive, basophilic. What do you think? I've got one answer which says hyalinizing. Very good. So this is hyalinizing fat necrosis. What is the infiltrate like? Lymphocytes, histiocytes, eosinophils, neutrophils. What do you think? Okay. What infiltrate is it? LHEN. Easiest way to think. Lymphocytes and histiocytes. Okay. So there are a lot of lymphocytes because they've got blue nuclei. Let's see under higher power what it looks like. So when you have lymphocytes, I've got another higher picture I'll show you. When you have lymphocytes, you usually think of lupus and lymphomas. In lupus, you should usually have an interface change with dermal mucin deposits, thickening of basement membrane, none of which is present. So you go back and see under higher power, you've got lymphocytes. You've also got cells which have engulfed karyotic debris. That's called hemophagocytosis with RBCs thrown in. So when you have cells which have engulfed other cells, other nuclear dust, you call it hemophagocytosis. With atypical cells lining the fat spaces, this is atypical lobular lymphocytic panniculitis. Without vasculitis, some hyalinizing fat necrosis. So next thing, what would you do? When you have atypical lymphoid cells, what's the next thing you'll do? You'll ask for immunohistochemistry. When you ask for immunohistochemistry, what we found is this patient was CD3 positive, CD8 positive cells lining the fat spaces with a high MIB1 negative or CD56. So we called it SPTCM. So let me end. So to summarize, first thing you ask yourself, is it septal or lobular? Remember, septal and lobular have equal distribution in adults. Lobular is more common in children. Next thing you ask yourself, is vasculitis present or not? If vasculitis is present, what is the infiltrate which is there? And what vessel is involved? If it's a medium-sized blood vessel, think of pan, or a superficial thrombophlebitis if it's a vein. If it's a small blood vessel, think of erythema induratum. If it's a lobular infiltrate, think of erythema induratum. If it's lymphohistiocytic, you ask yourself, is there fat necrosis? What's the type of fat necrosis that is present? What are the other changes that I'm seeing? What is the infiltrate that is present? And if you're seeing atypical infiltrate, ask for immunohistochemistry. So I'd like to end by telling you that panniculitis is a complex field where an in-depth knowledge of the variants and their typical histopathological features are necessary for your knowledge, so that you can increase the diagnostic accuracy of what you would give in your report, and to help the clinician to give a better treatment. And the answer is medium vessel vasculitis usually only involves one lobule, not the whole septa. Because like I told you, septa usually involves a vein, and it's a smaller, less inflammation that you have in the septa. Medium vessel vasculitis involves one lobule. So it's predominantly a lobular panniculitis.
The winner is Dr. Ramisha, madam. Dr. Ramisha from Andhra Medical College.
Very good. Congratulations, sir. So she's got the maximum number of right answers.
Yes, ma'am.
Congratulations. The second one is type of necrosis in septic panniculitis, where you have basophilic fat necrosis because of fragmented neutrophils and karyotic debris which is present. Okay. Ischemic fat necrosis seen when the blood supply is limited. Lipophagic fat necrosis when
Excuse me. One minute, madam. I'm just making silent.
Good.
Doctor, kindly unmute yourself and you can speak, doctor. Speaker mode,
You
kindly
have
unmute yourself.
basophilic lipophagic fat necrosis. You can be seen in erythema nodosum, traumatic fat necrosis, liquefactive fat necrosis, usually seen in pancreatic panniculitis or alpha-1 antitrypsin deficiency. Then the fourth one, which is what type of cell is seen in lupus panniculitis, is lymphocyte. You can see lymphocytes and plasma cells in lupus, neutrophils in septic or early erythema induratum, histiocytes in granuloma induratum or a histiocytosis or histophagocytosis syndrome, eosinophils in drugs, parasites, fungus, etc. Thank you for your kind attention. Any questions?
Thank you, Dr.
Sir,
Meera. Wow, very wonderful session. And it is more, I mean, you made it more interesting by making it interactive. Very good. Thank you. It is a good teaching session for myself as well as the students who are listening to it. Thank you, madam. I will disturb you once again when other topics are coming up. Thank you very much. I am sorry that I know you are not engaging Sundays as teaching. Sorry, but there is no other way that we have to.
No problem.
Yeah.
I love teaching. So thank you very much, Dr. Crichton, for inviting me. Thank you very much.
Thank you. Thank you. Thank you very much. Thank you very much. I think we can go to the next session.
Yes, sir.
The second session on today is about granulomas. Again, granulomas are very interesting as well as very confusing. Most of the time, dermatologists are stuck with granulomas. The pathologists say that there are a lot of granulomas and the differentials are very vast. And to know what is the cause for granuloma is also very intriguing. And Dr. Usha, all of us know Dr. Usha is a very good teacher, and she is running the CPC in Amala Medical College in Dermatology department, and she has a very huge experience in dermatopathology. And I think she is doing it for the last 7-8 years and now. So we expect very good discussion on cutaneous granulomas. Over to you, Dr. Usha.
Thank you, dear sir. Thank you for this opportunity. Am I audible?
Yes, yes.
Is my screen visible?
Yes, yes.
Okay, so like the topic given to me today is cutaneous granulomas. How exactly do we approach these cutaneous granulomas? As sir said, many a time we find it very difficult, in spite of seeing the granulomas, to delineate into which category to put into. So I'll just try to see how much we can get into it. So, one sec. Okay, so a granuloma is seen as a part of a granulomatous inflammation. So granulomatous inflammation is nothing but a chronic inflammatory response. So it is a type 4 or a delayed hypersensitivity reaction, which can be induced by an infection or a reaction to autoimmunity, toxins, allergies, drugs, and neoplasms. So in this picture, what you can see is this collection of pale staining cells. These cells are the epithelioid histiocytes, wherein you have these cells, the nuclei of these cells are elongated and they have a slipper shape. So that is why they are referred to as slipper-shaped nuclei. So you see this cluster of epithelioid cells, which is surrounded by mononuclear cells, which are the lymphocytes and the plasma cells. So this is what constitutes a granuloma. So these granulomas can show giant cells, or sometimes giant cells will be absent in these cells. Okay, in these granulomas. So let's see what are the different types of giant cells we come across. So first one is the Langhans giant cell. Here you can see that the nuclei are arranged in a horseshoe pattern. It can be either in one pole of the cell or in both poles of the cell. So this is the Langerhans giant cell. Please mind that this is not Langerhans, but Langerhans giant cell. The second one is a foreign body giant cell, where you see the nuclei scattered throughout the cytoplasm. The third one is the Teuton giant cell. Here you see a central cytoplasm surrounded by this ring-like nuclei, and surrounding that you see vacuolated cytoplasm. So this is the Teuton giant cell. The next one is the tumor giant cell, wherein you see the morphology is almost similar to that of the foreign body. You see the nuclei scattered throughout the cytoplasm. But here, if you observe, the nuclei are hypochromatic and pleomorphic. So these are all the different types of giant cells that we are going to come across now. So now let's see, this is a pictorial representation of the different types of granulomas that we are going to learn today. So the first one is the tuberculoid granuloma, wherein you see central caseous necrosis. So caseous meaning cheese-like. So this pink eosinophilic cheese-like necrosis is seen in a tuberculoid granuloma. Sometimes you may not see the caseous necrosis too. So it's not a hard and fast rule that you have to see, but if it is seen, then it favors tuberculosis. So this caseating necrosis you see in the center, you see this Langerhans type of giant cell, okay, and surrounded by the peripheral rim of mononuclear cells. Then coming to the suppurative granuloma. So within the clusters of epithelioid cells, we see a collection of neutrophils. So that is why it is referred to as a suppurative granuloma. Then coming to a xanthogranuloma, wherein you see abundant collections of foamy histiocytes along with Teuton giant cells. So this is a xanthogranuloma. Coming to a sarcoidal granuloma. Here you're seeing the epithelioid cells, and you're seeing this starburst-like inclusion within the giant cell that is referred to as an asteroid body, which is seen in a sarcoidal granuloma. Coming to the foreign body granuloma, wherein you see the collections of epithelioid cells along with many foreign body giant cells. The last one is the palisading granuloma, wherein you see central collagenolysis with surrounding a palisading of histiocytes. That is a palisading granuloma. Now we'll see these granulomas, we'll assort them into the different conditions wherein these types of granulomas are seen. So we've done the classification accordingly. So based on the types of granulomas, we're going to study the reaction pattern. So we're going to deal with the sarcoidal granuloma, the tuberculoid granuloma, necrobiotic granuloma, suppurative granuloma, foreign body granuloma, xanthogranulomas, and miscellaneous conditions. So the first one. So I think the dermatology PGs can tell this. What is the lesion that you're seeing here in sarcoidosis? Can anyone message in your chat box? Okay, so I'll just go to it. So I'm not dealing much with the clinical presentation. So they usually present with asymptomatic papules, which can later become disfiguring scars. So here they are asymptomatic. Sometimes they'll be warm and tender to touch. Now, what do we see in the histopathology? So here we see that the epidermis is thinned out, flattened, and we are seeing closely packed granulomas. And so in these granulomas, if you observe, you'll see that it is predominantly the epithelioid histiocytes and very few lymphocytes within the granuloma or in the periphery. Very few lymphocytes. So that is why these granulomas are referred to as the naked granulomas. And within these granulomas, you will also observe something called the asteroid body, which I showed you earlier, the asteroid body. So the starburst-like appearance, eosinophilic inclusion, which is seen within the giant cell. You also may see the Schaumann body. That is also a finding that you see in sarcoidosis. Schaumann body, that is the chalcospherite, a calcium inclusion, which is seen in the giant cell. So these two are usually seen in sarcoidosis, but please remember that they can also be seen in other granulomatous inflammations too. So whenever we are dealing with such granulomas, you always have to remember that sarcoidosis is a diagnosis of exclusion. So you always have to do special stains whenever you see granulomas, such as the PAS stain or the GMS stain for the fungal organisms, acid-fast stains to detect the bacilli. So when you rule out all these infectious etiology, you correlate it clinically with ACE levels, calcium levels, and other findings to come to the diagnosis of sarcoidosis. So you do not straight away go to the diagnosis of sarcoidosis. It is only a diagnosis of exclusion. So you should remember that these sarcoidal granulomas are non-case-sitting granulomas. It can also be seen in atypical mycobacterial diseases, fungal diseases such as coccidiomycosis and histoplasmosis. Another thing what I wanted to add here is these asteroid bodies and Schaumann bodies can be seen in other conditions I told you. They include berylliosis, hypersensitivity pneumonitis, and other etiologies such as tuberculosis. It can also be seen in tuberculosis and Crohn's disease. So these are all the differentials that you should consider. Okay, so can anyone tell me what stain this is? What is the stain that is used here? Whenever we come across a case of sarcoidosis, we always do this stain. So you can see that this is the, has anyone given the answer? Yes, this is the reticulin stain which is done. You can see that the reticulin framework is rich within the granuloma and surrounding it. So this is a reticulin-rich framework. So this is usually seen in sarcoidosis. Whereas in tuberculosis, if you do this reticulin stain, you will see the breakdown of the reticulin fibers. So this stain usually helps us to tell whether this is sarcoidosis in addition to the other special stains. So we're going to come to the tuberculoid granulomas. So tuberculoid granulomas are seen in many conditions such as tuberculosis, leprosy, fatal bacterial granulomas, late syphilis, Leishmaniasis, rosaceae, idiopathic facial aseptic granuloma, perioral dermatitis, and even in Crohn's disease. So tuberculosis, the cutaneous tuberculosis, they can present as papules, nodules, and usually as painful ulcers. Now in this picture, if you see, you can see that there is this area completely shows caseating necrosis. So the pink eosinophilic material, cheesy material. So that is a caseous necrosis. You can see a sprinkling of lymphocytes. You can see multinucleate giant cells, both Langhans type and the foreign body type, along with histiocytes and mononuclear cells. So this is what is seen in tuberculosis. So we have to confirm it by doing the spatial stain. So here the Zeal nasal stain picture is shown where you see the rod-shaped bacilli, which is with the help of this stain, we can conclude with the diagnosis is tuberculosis. Coming to leprosy. Here also we see tuberculoid granulomas, as I said earlier. So the patient can present with asymptomatic hypopigmented patches or well-defined dry scaly patches. Coming to the histopathology. So here we can see that I'm only dealing with the tuberculoid leprosy because we see these granulomas in tuberculoid leprosy. So here we can see that the epidermis is thinned down in this area. You have granulomas in close approximation with the epidermis, and you can see them extending downwards up to the deep dermis. What is peculiar about these granulomas is that they follow the neurovascular bundles. So when they follow it, it gives a curvilinear appearance, which is referred to as a serpiginous granulomas. So you can again see that this is a cluster of epithelioid cells, lymphocytes. And if you do a special stain, that is the modified Phyte stain, you will see the acid-fast bacilli. So in tuberculoid leprosy, we do not see much of the bacilli, but even if we see one bacilli, we are happy. We say yes, it favors tuberculoid Hansen's disease. Coming to the next condition, which is a new entity. I do not have the histopathology picture. I just wanted to mention it. It was reported in rural China. Here, following a slight trauma to the face, rapidly spreading dark red plaques developed. The epidermis was normal, but the dermis showed a diffuse dermal infiltrate of histiocytes along with lymphocytes, plasma cells, neutrophils, and multinucleate giant cells. In addition, there was also vascular occlusion with hemorrhage and necrosis. So this condition has a high morbidity of 1.5 to 2 years. Then coming to the next condition, that is syphilis. So syphilis, in the late stages of syphilis, we can see that there is proper granuloma formation. So what we're seeing here is the epidermis, and just below the epidermis, we're seeing granulomatous inflammation. So if you look closely, many of these cells, so we have epithelioid histiocytes, we have lymphocytes, and also what we're seeing prominently here is the plasma cells. So syphilitic granulomas usually have a predominance of plasma cells. So how will we come to the diagnosis, or how can we be certain that this is a syphilitic granuloma? So can anyone tell me what is a special stain done here? Anyone, can you include that in your chat box? What is this special stain done here? So this is the silver stain, Wathan starry silver stain. Here we can see the spirochete, the spiral organism, the spirochete. So when we see this, we'll come to the diagnosis, yes, that this is syphilis. Okay, next coming to Leishmaniasis. As we know, it is caused by Leishmanial organism. The patient presents, how does this occur? It is because of the bite of the infected sandfly. So soon after the bite, the patient presents with papules. After 2 weeks, they come with ulcerating lesions. So what we're seeing in this histopathology is, again, granulomas. You have a collection of epithelioid histiocytes, but you can all see very clearly that there are small, tiny organisms within these cells. They are the amastigote forms of Leishmania. So you see, it has a well-defined, small, rounded organisms with the nucleus and the kinetoplast. So this is characteristic of Leishmaniasis. Here, we do not, most of the times, we do not need the special stain to demonstrate this organism, but at times, we can use GIMSA if it is not clearly visible. Okay, coming to the next condition, that is rosaceae. Patient presents with persistent erythema and telangiectasia. They can present with papules, pustules, dilated blood vessels. It's usually seen in the cheeks, the chin, the nose, and the forehead. Can be seen in children and adults, and also in association with HIV. It's usually because of a hyperactive immune system. So the findings that we see here, in early conditions, we see only perivascular lymphocytes. But in later stages, we can see well-formed granulomas around the vessels or around the follicles. So they are tuberculoid granulomas. In addition, we can also see acute folliculitis and dermal edema and vascular dilatation. So these are all the findings that we see in rosaceae. So the follicles will be involved. You can have perifollicular granulomas or just perifollicular inflammation, acute inflammation. You can see dermal edema, dilated vessels, in addition to the tuberculoid granulomas. Coming to the next condition, that is idiopathic facial aseptic granuloma, usually seen in children. They present with painless nodules on the face. It is believed to be a spectrum of childhood rosaceae. It was believed, but it is unlikely now. Now, the histopathology that we see here is again granuloma formation with lymphocytes, histiocytes, and you can see a Langhans giant cell, and you can also see foreign body giant cells. So this is again believed to be a variant of rosaceae. The findings, the histopathology will be very similar to that of rosaceae. Coming to childhood granulomatous periorificial dermatitis. Here what we're seeing is red papules or papulovesicles around the periorificial region, and it's usually believed to be seen in Afro-Caribbean descent people, in children. So the histopathology is very similar to rosaceae. It is a clinical diagnosis which will help us reach the diagnosis. Coming to again Crohn's disease, again you see a similar morphology in histopathology, just like in tuberculoid granulomas. But here you have non-caseating granulomas, which are seen in the dermis and the subcutis. So if a patient presents with metastatic Crohn's disease, you will see multiple cutaneous lesions. So you need the correct clinical history to come to the conclusion. So now we are moving away from the tuberculoid granulomas. We are going to the collagenolytic or the necrobiotic granulomas. So the various conditions that wherein you can see these necrobiotic granulomas are granuloma annulare. This is the prototype. You can also see it in Necrobiosis Lipoidica, Necrobiotic Xanthogranuloma, Rheumatoid Nodules, reactions to foreign materials and vaccines, and miscellaneous diseases. So the first one, granuloma annulare. You know it is a self-limited dermatosis. You do not know the etiology. You see these necrobiotic papules in annular configuration, seen on the hands, feet, arms, legs. So here the skin and the subcutis are both involved. So you can see the histopathology here. The epidermis is unremarkable. You can see the basket weave keratin, the epidermis. But what you're seeing in the dermis is striking. You can see that the collagen has broken down. So there is collagenolysis here. Here you can see that the infiltrate is around this breakdown of collagen. So in granuloma annulare, you can get an interstitial pattern or a palisading pattern. Here in the palisading pattern, you can see that the central necrosis is surrounded by a palisading of the histiocytes. So this is a palisading granuloma, which is seen in granuloma annulare. Coming to Necrobiosis Lipoidica, it is usually seen in association with diabetes and also in other autoimmune conditions. Here the patient classical appearance, so they have red papules which enlarge into patches, and the central area will be atrophic with shiny yellow-brown center. So recent detection of Borrelia burgdorferi has also been seen. Now what do we see in the histopathology? Here we're seeing that this lesion is involving the entire thickness. So we have a thinned out epidermis, and we are seeing that the dermis and the lesion is involving the entire thickness of the dermis reaching up to the subcutis. So there will be dermal fibrosis, and you can have superficial perivascular infiltrate, deep perivascular infiltrates, along with lymphoid aggregates. Okay, in this picture, we are seeing that in multiple areas, you can see the area involvement by the inflammatory cells and with surrounding dermal fibrosis. You can also see endothelial swelling within the blood vessels and sometimes even vasculitis. So that is seen in Necrobiosis Lipoidica. Now in Necrobiotic Xanthogranuloma, we see classical plaques and nodules in the periorbital area. So patient can also present with paraproteinemia. So as Dr. Meera said, the hyaline, so pale, glassy hyaline necrosis is what we see here, hyaline necrobiosis, along with granuloma formation, which is composed of histiocytes, foamy cells. You can see a lot of foamy cells, along with multinucleate giant cells. But at times, the distinction from Necrobiosis lipoidica becomes difficult. We need a proper clinical correlation. Coming to rheumatoid nodules, it's more of a clinical diagnosis than a histopathological diagnosis. You can see these fibrous white masses. If you cut them, they'll have creamy yellow areas, and they use 20% is seen in the vicinity of the joints. It can affect the subcutaneous tissue. It can affect the deep dermis and the superficial dermis. So again, what you're seeing here is central area of necrosis, which is more of fibrinous necrosis, along with palisading histiocytes. So here again, we get palisading granulomas with fibrin in the center. Here we're seeing a lot of inflammatory cells with epithelioid histiocytes and multinucleate giant cells. Now, moving on to the next one, that is the suppurative granuloma. Here we see suppuration, as I said, it's a collection of neutrophils. We're seeing the granuloma with a lot of neutrophils in the center and surrounding mononuclear cells. Again, whenever you see suppurative granulomas, the first thing that should come into your mind is it fungal in origin? So you have to do special stains to rule out a fungal etiology. So the special stains for fungus, as we said, are PAS and GMS. So all the conditions of the fungal infections such as chromomycosis, pheohypomycosis, sporotrichosis, blastomycosis, coccidomycosis, mycetoma, all of these have to be ruled out. So the other non-fungal conditions are non-tuberculous mycobacterial infections, cat scratch disease, LGV, pyodoma gangrenosum, and also the ruptured cysts and follicles, which can show suppurative granulomas. Coming to the foreign body granulomas, the foreign bodies can be either exogenous in origin or endogenous in origin. So when it is exogenous, the things that can cause are starch, talc, tattoo, cactus, bristles, wood splinters, and suture material. So what we're seeing here is the tattoo material, so black pigment that is seen. So endogenous can be calcium deposits, urates, oxalate, keratin, and hair. So here what you're seeing is a suture material within, surrounded by many foreign body giant cells and along with histiocytes and mononuclear cells. So this is a suture granuloma. Now what you're seeing here is multiple two-tin giant cells and many foamy histiocytes. This is classically seen in xanthogranulomas. This does not have a differential. Whenever we see this, our diagnosis is xanthogranuloma. So the last one is the granulomatous slack skin disease. So here the patient presents with loose skin, the slack skin. Okay. So can anyone tell me what is this? What is granulomatous slack skin disease? Can you put it in your chat box? What is it? Not able to see it. Yes. Very good. Correct. You're all right. So this is an indolent T-cell lymphoma. So what do we see in this indolent T-cell lymphoma? You see, if you look at this slide, you can see that the epidermis is markedly thinned out and you're seeing a diffuse infiltrate, which is extending right from the superficial dermis up to the deep dermis and even up to the subcutis. So then how do we differentiate this from the normal lymphoid cells? So you have to look carefully. You can see that there are collections of epithelioid histiocytes and along with these lymphoid cells. If you look at these lymphoid cells, they are larger and they're pleomorphic with irregular nuclear contour. So we should not write it off as just lymphocytes. You have to look at the lymphoid cells closely. You have to look at their nuclear outlines. They're irregular. They're larger than the normal lymphocytes. So this is a diagnosis of indolent T-cell lymphoma. So I think we're done with that. Shall I go ahead with the test? Just 5 slides. You can just, it's a very simple one. Just if you've listened to it, you can answer it easily. Shall I start?
Okay. Go ahead.
Okay. So the first one. What is this body? And name 2 conditions wherein you see this. You can put it in your chat box.
What time starts now?
Very good. I'm seeing so many right answers. I'm very happy.
Yes.
Shall we go to the next one?
Yes, madam. We can go next one.
Okay. Okay. Can you describe the cell and tell me the condition wherein you see it? Very good. We'll have a lot of winners this time. Shall I go to the next one?
Yes, madam. You can proceed.
Sorry, one sec. Okay. So what type of granuloma is this? And what are the special stains which are needed here? Very good. I've got the answers. Okay, so we'll proceed to the next one.
Yes.
What do you think of this? What sort of granuloma is this? And what is your possible diagnosis and the special stain needed to confirm? Very good. We'll go to the next one. Okay, here there's no picture. Just name the special stain to help differentiate between sarcoidal and tuberculoid granulomas. 2 special stains. Very good. We've got the answers. I'm really happy. Thank you so much. Thank you, sir, for this opportunity.
And thank you, Dr. Usha, for the wonderful presentation. And again, it is a good learning time. And I am sure that most of our postgraduates who attended the webinar must be benefited. And you have given, both of you, in the today's talk, they give a very, very lucid talk, and they should understand what is meant by panniculitis, what is meant by granuloma. Thank you very much, and congratulations. Thank you.
Thank you.
Thank you.
My request is for all postgraduates to kindly inform your colleagues also, and also inform your Pan-India group. Please post it and let them also be benefited. And thank you so much. Have a good day to all. Happy learning.